Hands up. Any questions for Thivi? One here. Shout out if you haven't got them. There's a microphone coming.
I'm American, I can shout out pretty loudly without trying to. But I'll speak softer now. Many of us would probably enjoy, or do enjoy, South Asian and Asian diets as well. I mean, stir-fried things, lots of dals, lots of lentils and other forms, all sorts of things. Have you done any comments, basically?
Absolutely. So the key about having a nutritionist is they adapt a Mediterranean diet wherever you come from. Whether you're having a Caribbean-focused diet, whether you're having an Asian diet, East Asian or South Asian, all of them can easily be adapted. So you swap out the ghee for olive oil. You've got the lentils there already. You know, the basis of the Mediterranean diet can be applicable to any eating pattern across the world. It just has very core constituents that you need to remember to include.
So, sorry, just carry on. So things like fiber and fats and things are known for those other things and can be...
Yes, exactly,
right.
exactly.
I think that's what's just not as publicized.
Exactly, and actually that's part of the work that we did is creating, you know, for example, if you're going to eat in an Indian restaurant, what sort of foods would you eat? Or if you were making that at home, how could you adapt that to a Mediterranean? It doesn't need to be what we sort of, you know, sitting there with a Greek salad and a piece of grilled fish. It is very much a diet that can be tailored to whatever your eating pattern.
Question there.
Thanks. Just to ask you about milk versus non-milk, like Oatly.
Yes.
So I tend to now just have Oatly, but it's got sugar in and it's processed. How would you compare that then with dairy, you know, cow's milk?
Yes.
Is there
So that's
on
a question I
balance?
get asked all the time, and it depends. Why are you having oat milk? If you don't mind sharing, why did you switch to oat milk?
Partly when my niece went vegan,
Okay.
and I was using that, and then I just feel bad for the cows who lose their calves.
So for ethical reasons. So
Yeah.
if you're doing it for ethical reason, you want to choose a plant-based milk that is fortified. And fortification means it should say fortified. And when you turn it on the back, it's got vitamin D, it's got calcium added, it's got B12. You want to make sure it's got all those things added that is so beneficial in cow's milk, because cow's milk actually has a lot of very good things in. Especially, someone was asking me about their daughter, maybe they were 21 or something earlier. Yes, you were asking me about your daughter. And actually, particularly, you know, for osteoporosis and bone density in women, I'm very careful about telling people to go, you know, dropping the milk out of their diet if they don't need to. I have milk all the time. So if your gut is okay with it and it doesn't cause you gut upset, it doesn't flare your psoriasis for any reason that it might do, or your eczema, whatever else you're living with, and it's not an ethical consideration, then cow's milk is still recommended. But for ethical reasons, if you're going to a plant-based milk, you have the choice of soya milk, you've got nut-based milk. That is personal preference. I tend to recommend oat milk less because, yes, it can push your blood sugar up a bit higher. If you're having it, you would want to have it as part of a meal rather than on its own.
Can we... two quick questions and short answers for Thivi, because then otherwise we won't get on to other bits and pieces. Sue.
Thank you. Thivi, really enjoyed it. GLP-1 agonist effect on inflammation, direct or secondary due to loss of adipose tissue, do you think?
I think it's both. I think it's weight loss, and I think I've collected about 10 or 12 patients so far who've had these drugs, and now I actively send them to Professor McGowan, who's next door to me, who's a professor of obesity at Guy's, but I work with her elsewhere. And so I actively send people, and I think it's both. I really do. I think that we know so much about the beyond weight loss effects of these drugs now. I don't think they're a cure, and I don't think they replace diet, but I think for the right person, I think they're massively helpful.
Last question for Thivi here. We'll come back, but I just want to engage the others as well.
I've just...
In the middle here. Question in the middle.
Hi, I'm Michael. I was thinking about milk.
Yes.
You have full-fat milk, semi-skim milk,
Yes.
and skim milk. I always have full-fat milk because I like to have my cup of tea with full-fat milk. But is there any difference, or should we go with one?
It completely depends on what your aim is. If you have high cholesterol, you absolutely should not be having full-fat milk. I don't know your medical history. I probably don't want to announce it to the room either. But so full-fat milk. But if you're having a splash in tea, I always ask, where are you having this milk? If you're having it in your porridge, you know, a cup. If you're having it in your cereal, then you may want to think about a semi-skim milk if you're trying to manage, for example, weight, if you're managing cholesterol. But if you're just having a splash in your tea, I'm easy. Have your splash in your tea.
Right. We'll develop this bit. Every speaker talked about morbidity, mortality, and Darren introduced it. Andrew talked about the side effects of drugs and managing people with comorbidities. And Thivi, I think it was on your first slide, you had psoriasis as a multi-system disease. So the idea of taking psoriasis in isolation is challenging. So let's start. And the question from the audience was about, because we've got psoriasis, are we going to die younger? And if we are, how and what can we do about it? Let's, Darren, could you just sort of reintroduce this? When you're looking at mortality figures, let's say, and comparing psoriasis, and looking at saying psoriasis is higher than the general population or whatever the control group is, there must be in that data a lot of confounding variables. Obesity, for example, cardiovascular disease. Are you able to control for that? And what advice should we give our patients based on that data? Does that make sense?
Yes, certainly. And mortality, is the hardest outcome that we can look at in any study. And to a degree, it's really important to try and understand what are some of the drivers of some of these differences in mortality between people with and without psoriasis. And essentially, the analysis, what we've shown is kind of rates of mortality that show over time we're seeing a reduction in mortality, which is positive. But I think the most important thing that I wanted to draw attention to is that mortality gap, and that isn't closing, I think. So that's the bit where I think we need to spend a lot more attention. We've started to look at what are the kind of categories that people have coded for on death certificates, because that, I think, provides indicators of what are those primary causes. And we can see they do cluster in particular groups, and they do relate to a lot of discussion we've talked today about, diets, if people are smoking, if they're drinking too much alcohol above recommended levels. These are all markers, I think, that we can manage and behave. The question about whether we want to control for that or not, I'm not sure we do. I think we want to unravel what are the drivers of that, but I don't think we want to kind of explain it away. I think we want to kind of highlight some of these areas and then develop appropriate interventions to support people to manage some of these aspects of life that are challenging but potentially are preventable, I think.
So a quick question for Catherine, and I'm going to open it up to the floor, if I may. So thanks, Darren. Catherine, we talked a bit about disease association, confounding variables. And because one thing's associated with another, it doesn't necessarily mean that it causes it. Are there ways that we can try and unravel that sort of helps patients understand interventions, lifestyle, etc.? If that makes sense.
That's a good question. The association and whether it's causal. Well, I mean, genetics can help us. So we recently did a big study because there's been this long-running discussion about the link between psoriasis and cardiovascular disease. So we know if we take a population of people with psoriasis, there's more cardiovascular disease. And is it that the psoriasis is driving the risk of cardiovascular disease? And actually what we've found is it was the other way around, that the pathways that lead to heart disease are also probably the same pathways that lead to psoriasis. So it's not that the psoriasis is causing the heart disease. So I think for patients what that means, I mean, I take your point, Darren, that we don't want to explain it away, but I think it's also important for people to say, well, to understand that it's not their psoriasis necessarily on their skin that's causing all of these problems. So I think that's a key takeaway, because we need to understand the association and that gap, but it's not all necessarily caused by the psoriasis.
Great. It's open to the floor, right at the back.
It's a really similar question to the one that you just answered, probably mostly for Catherine. It's kind of two questions. To what extent does the severity of psoriasis plaques on the skin correlate to the risk of other effects like cardiovascular disease, respiratory disease. And then the follow-on from that is a treated psoriasis more likely to reduce the risks of those other things, or is there not as strong a correlation?
Very, very, very good question. We know, again, the association of all this comorbidity, it's called, is mainly in people with more severe disease, as defined by having it more extensively on your skin or requiring systemic therapy. So that's what the big, well, Darren, you can talk about that as well, but I mean, that association. But so we know it's mostly in those, that group, but that does not mean necessarily that it's a severe disease that's causing the comorbidity. So your question is, does treating it reduce it? I'm not aware of any really powerful studies that's showing that yet, actually. There's some suggestion, surrogate proxies, I suppose, but I think what's important is treating psoriasis properly is the main goal, and we'll have to wait and see whether in the long term it does have an impact. Yeah.
Thank you. Lady over there.
Is there a link between psoriasis and liver? Because I've got psoriasis, but I've never taken any medication. But yeah, when in December my liver function and my liver blood results were normal, I developed psoriasis in January, and in March, when I was thinking of going on medication, I couldn't go on a particular one because my liver was elevated. So is there a direct link, do you think?
Yeah. Do you want to answer?
Yeah, so I think the pathways we know are quite similar. So one of the inflammatory cytokines, one of the inflammation molecules that is involved in psoriasis is also involved in the liver as well, and that's IL-17. And we know that those two are shared between. And the liver people are looking at IL-17, and we're looking at IL-17 as well. So,
but is there anything that I can do? I mean, my psoriasis, touch wood, is kind of not as severe as it was. I'm still not on any medication. I'm watching my diet. So do you think that perhaps in 6 months' time that my liver will return to the normal level, or will it always be elevated?
Difficult,
I think it depends a bit on knowing a bit more about you as your actual individual case. But I think that liver tests can definitely improve, and keeping a healthy weight is really important as well. And we know that is key. But we do also know that there is prevalent liver problems in people with psoriasis. But having said that, also that shouldn't stop you being treated for your psoriasis. So there are lots of treatments available for psoriasis that are compatible with having upset liver tests. So I think the two need to be treated in tandem, and so don't wait, is what I would say.
Any other questions? Sue again.
Darren, really enjoyed that data, really fascinating, in particular that mortality gap that you mentioned is not closing over the years. And I wondered whether you have any insight from your epi-data on, is it because of the access, early diagnosis of these comorbidities, or is it a matter of management issue of these comorbidities that led to death?
Thanks, Sue. And we have done other work looking at comorbidities in people with psoriasis compared to people without psoriasis. I think you've highlighted a really important point there. When we looked at the onset of comorbidities, they did occur at a much earlier point very often than what they do in the general population as well. So that is, a very important consideration. And I think the theme running through a lot of the discussions today is about this more holistic approach to psoriasis. It's much deeper than skin symptoms, etc. And I think that needs to be central, I think, going forward, thinking about not only the management of the skin manifestations, but a more holistic approach around management of relevant comorbidities as well.
Julia?
So I just wanted to pick up Stephen's comment, because he asked specifically about cancer. So because there'll be a lot of people in this room that will be worried about those data that showed about cancer. And I just wondered if we could pick that one up. Is it related to excessive smoking in the cohort? And if you correct for smoking, do you take away the cancer risk? Can you help us with that one?
So We've recently completed a number of studies looking at a range of 20 cancers in people with psoriasis and without, and we had the beauty with colleagues to replicate some of that work in not only the UK, but with colleagues in Taiwan, Denmark and Israel as well. And that work will be published shortly in the British Journal of Dermatology. So we do see signals of higher rates of a number of different cancers. In terms of what we can see in the epidemiological data, consistently we see, if we compare a population of people with psoriasis, randomly sampled compared to those without, that there are higher levels of smoking, there are higher levels of alcohol consumption, and there are also very often these people are more overweight or obese within that population, and that cuts across the different samples. We know each of those factors are recognised risk factors for cancer. So I think the link to a degree is bringing that science together and thinking about the interventions now, some of which we've been hearing about today, that we can start to bring more routinely into the clinic environment to support individuals on their psoriasis journey.
So it brings it back to Chris's point, which is Chris Dyer's point when she asked about who's dealing with all of this. You know, I thought that was a really powerful point. So what we've identified is that if we've got 3 factors there that relate to cancer risk, which is alcohol, smoking, and increased body mass index, and actually all of our patients should be receiving some sort of holistic advice about those factors, because we know that those are all relevant for cancer risk. And if you were slim, good diet, etc., didn't smoke, your risk might not be very high of cancer. Is that right? Is that a message that the group can take away?
Yep.
I think so, definitely.
Yeah,
and as well as, you know,
So,
alongside reducing your risk of cancer, it may also have beneficial effects on your psoriasis as well.
Julia, my take on it, my personal take on this is a very important point, is if you look at populations of people with psoriasis, there's all these other comorbidities, all these other, if you like, bad lifestyle issues going on, generally speaking, are more common in people with psoriasis, generally speaking. But if you then ask the question, is any of these things specifically related to psoriasis in the absence of any of these other, is the jury is out, and maybe there's a little signal. So people with psoriasis, like people without psoriasis, should live well, holistically well. And the added benefit, if you've got psoriasis, your psoriasis might actually improve a bit. So there's a question over there.
Can I just want to make one other comment, actually, also? Is although these things might be lifestyle factors, living might be a little bit more common in people with psoriasis, still, the majority of people with psoriasis aren't necessarily massively overweight or smoking or drinking. I think there's this sort of stigma around the fact that people with psoriasis, you know, got psoriasis because they live bad lives, and actually most people, it's not true. So we're just looking at a slightly increased frequency, and it's a very, very important point.
I think you've just saved the day, because I'm going to stand up and say I was 14 and 15 when I was diagnosed with psoriasis. I'm now 87.
Has there been any research between, you know, you were talking about the weight loss medication and you were saying that some patients don't come back. Has there been any research between the two, psoriasis and, say, Ozempic, or is that just because people are, I guess, not eating as much and not wanting to eat as much, or is it the actual medication?
There hasn't been a good trial yet.
Okay.
There will be a good trial. If you saw the My Skin app,
Yeah.
I think I've pulled my thing out. There was a little QR code to sign up if you're interested, and you should definitely sign up for that. We should probably put that QR code up again, because I think there'll be a lot of interest in it. From the States, and our colleagues in the States are a lot more sort of, they're prescribing it, and they're happy to. So dermatologists in New York, Professor Lebwell, you might have seen his name on some of the slides, very prolific publisher, is prescribing these drugs to people who are living with psoriasis.
I'm just wondering if it's because I've heard, you know, friends and you know, whoever, they haven't been eating as much, so I guess they're going into fasting hours themselves.
Could be, yes,
So
we
is
don't
it
know. Yeah, I mean, you'd need to do proper food diaries to know. Is it what you're eating? Is it the fact that your timing of eating is different? Is it because you lost weight? Is it because your inflammatory markers went down because of the weight? We don't know. There's so many unanswered questions. but hopefully they'll be
No, I
answered
think
soon.
that's the point. The mechanism isn't, we don't understand.
Yeah, I'm just wondering if it's the actual medication or if it's the food. More work to be done.
Yes, but it'll be interesting when it does come out.
To do the work.
Can I just make a really quick point? Because we've talked a lot about unhealthy eating habits in people with psoriasis, and I think it's really important to stay. Sylvia actually did a lot of work before the research, doing work with people who had psoriasis and looking at eating habits. And people whose psoriasis severely impact their quality of life, of course they're going to want to snack in the evening. Of course they're going to comfort eat. Of course they are. These are normal behaviours of anybody living with any severe condition. So I think we have to be very cognizant of that when we are giving any dietary advice.
Thank you. I'm a dermatologist, and thank you, Dr. Thivi, for the last comment, because when we were talking about bad lifestyles, or people with psoriasis tend to smoke more or have unhealthy lifestyles, and that's because they are stressed, and that's because they smoke because they're stressed.
Yeah.
And obviously that can flare psoriasis. So my question was, in terms of the holistic management that we've been discussing, how important do you think stress, psychological stress, is in terms of how much it impacts psoriasis? So we know there are 1,000 factors. How important do you think stress is? And for context, I am looking to research this, and that's how I ask. Thank you.
I think actually Manpreet really covered that so well in her talk. It was an earlier talk and probably really good. Did you? I don't know if you saw that. It was fantastic. And it was really looking at people who live with psoriasis and what their big triggers were. And stress is up there. And we know that because we see people who, have a baby and don't sleep. We had one person drop out the study because his psoriasis flared and he couldn't stick to anything and his baby was not sleeping. And, we know these things are real, absolutely real factors in psoriasis severity.
I was also thinking that as we're getting older, and I know somebody was either talking about getting older, how that affected everything in light of what we've been through, and also the risks of the medications we're having now.
Those are all very good points. And I'm just thinking that with Darren telling us that there are more people living with psoriasis for longer, maybe in the future at this meeting, we should be considering older people with psoriasis.
Yes,
Because remember that clinical trials have a cut-off at the age of 65. Yeah, they don't, or sometimes 70, but nearly all 65. So all the data and how we manage is a little bit empirical in older people. And on that happy note,
Can we just,
we're going to go
thank you very
we're
much.
going to go into the
they
exciting
can't.
event called the
No.
AGM. Isn't that right?
Okay, so thank you very
Thank
much
you for
to our
the panel.
panel. Thank you very much to all our speakers. Thank you very much, Jonathan.